Yeah, I think it's important to think of it as not just designed for international doctors, but it's also designed for the system as a whole to relieve pressure on everyone.
Yeah.
Because we should not be having folks who did their residency already successfully, safely, in line with the same folks who have not completed their residency. It just does not make any sense.
Hey, everybody, welcome to the TIMGA Podcast. My name is Mohammed Khalif, and today I'm here with Lawson Mansell, Health Policy Analyst at the Niskanen Center, a think tank known for its evidence-based policy work. Lawson, welcome to the show, man. Really excited to have you on. How you doing?
Good. Thanks so much for having me. It's been great to watch the journey of TIMGA and everything you've been doing. So just glad to participate and contribute however I can.
Yeah, man, I really appreciate it. I know, like, I've, when we had our bill here in Washington, I reached out to you a couple of times. I'm like, hey, Lawson, come and, give us some, help right here, and talk, whatever you can say about, IMGs, and, you were just immediately, you replied to my message. You were like, yes, I want to participate. I want to help out. So, and I just, seeing your work on, the rest of the country, and, the folks that you're working with. And so before we get started, how did you get into this space, man, of policy work and, and working with the Niskanen Center? So how did everything start with you?
Yeah, so I grew up in South Carolina, where I sort of was first involved in policy work. I initially started out on the Hill. I worked for a member in South Carolina, spent some time in DC, worked back in the district in South Carolina, and then that was sort of my first exposure to policy work. But I had the opportunity, kind of where my healthcare journey started, was had the opportunity to work in South Carolina at a state think tank called Palmetto Promise Institute. They did a lot of work sort of surrounding how to help, particularly like independent doctors and folks who wanted to start facilities, build them, how to remove licensing barriers to certain medical personnel and clinicians. And so I kind of got the experience of realizing how difficult it is for some doctors to both build new clinics, to get licensed when they need to, and even working in like I worked with barbers and others who needed help with licensing issues. Just realizing how onerous and unnecessary some of the licensing requirements were at the state level. I mean, that's
Yeah.
kind of what got me interested in this issue. And then I've been a fan of the Niskanen Center for a long time. They do a lot of really excellent work. They work with both sides of the aisle and pursue solutions. And just advocate for policies that work for real people. And so I've been there for about a year and a half. And once I started, this was sort of the number one issue that I wanted to
Nice.
convince Niskanen to work on. They do a lot of immigration work, but they hadn't kind of dipped their toes into like the healthcare side of this. So it's been really nice to kind of work on how to address the physician shortage with doctors we already have in this country, and potentially with immigrant doctors as well.
Nice, man. Really great, work that you guys are doing over there. Talking about like the landscape of healthcare in America, and we all know healthcare is so complicated, and it's not like there's not like 2, 3 lines that you can read about and say, "Hey, I understand America's healthcare."
Right.
But when it comes to the physician workforce, so for people who don't know, or who have less information about it, like, yeah, I know the Niskanen Center worked on a lot of studies, like how much is the U.S. Spending compared to other states and all that. Is it a lot? Is it less? When it comes to kind of creating or producing doctors, what's the landscape of America when it comes to that?
Yeah. So I think you get a lot of different answers from different people, particularly when it comes to how our supply of healthcare, supply of physicians interacts with kind of our spending. But one thing is really clear, and that is that the U.S. Has a particular struggle with being able to get like high value healthcare. That is that
Mm.
we spend a lot of money on, and it's because we have an aging population. We have a population that suffers from a lot of chronic illnesses, particularly obesity. And so as a result, you're going to get a lot more. And we're also a very wealthy country. So we're going to spend a
Mm.
lot of money on healthcare as a result. But when you have a lot of demand for healthcare, particularly due to an aging population, like I said, chronic illnesses, you need a supply that can both match it in the total, in terms of like you need enough doctors to meet the demand, but also the type of doctors that can treat the kinds of things that Americans struggle with. And
Mm.
the US has a unique problem in that we don't have enough primary care physicians relative to other countries, particularly wealthy countries that spend similar amounts that we do.
Yeah.
And as a result, when you have a population with high needs when it comes to primary care and not enough primary care doctors, that's a major failure, a policy failure.
Yeah.
So there's a lot of reasons why we have a primary care shortage. We can get into some of that, I'm sure, as we go throughout this episode.
Yeah.
But I think that's probably the most important pressure point right now in when it comes to what Americans need and what we're unable to deliver. I think there's a lot of other things you can get into when it comes to the hospital side and the drug side, but when I think about the doctor issue, I mostly think of it as a primary care problem. There's also a
Mhm.
big psychiatry shortage as well. We need a lot more psychiatrists than we currently have. But if you look at specialists, and for those who maybe aren't familiar, specialists like a general surgeon or an anesthesiologist, someone who's not a generalist, doesn't practice primary care, we have a kind of a similar amount per capita of those folks than European countries that spend kind of what we spend on healthcare. And so,
Mhm.
we definitely have geographic distribution issues with specialists. Specialists often aren't in rural areas where we need them. But primary care, emergency docs, those are the kind of doctors in rural areas that we need a lot more of. And so, when I think about the issue like international physician licensing, we
Yeah.
definitely think opening pathways for international doctors is 100% a way to address the primary care problem.
Yeah, and I hear you about psychiatry because when we were working on some policies here in Washington State, I was speaking with a psychiatrist, and he works with Sound Mental Health, which is one of the biggest mental health facilities here in Washington State. So they're everywhere, and he was telling me, hey, like our entire facility just has 3 psychiatrists in the state.
Yeah.
So yeah, it was kind of like eye opening, like wow, and we tried, and you said there's so many ways that we can address the physician shortage, and there's been a lot of efforts made by the states in the past, like in one go to that every a state goes to is having more medical schools, right? And
Mhm.
nobody talks about the residency and like what happens after medical school, but a lot of states and leaders are like, hey, we need more medical schools. Do you come across that question, and what is your response to that?
Yeah, it's a good question. So, I mean, for those who aren't familiar, there's kind of two primary steps that, in terms of like what a doctor needs to accomplish before they can start getting fully licensed to practice, and it's medical school and residency. There's also fellowships and other things, but uh, in terms of medical schools, I mean, just think about like if you're a prospective student and you want to apply to medical schools, you have about a 50-50 chance actually currently to get in.
Yeah.
50% of folks last year who applied to medical school didn't get in. And now, you could look at that and say, oh, well, that means we're highly competitive. But for me, I think it's probably not a 50-50 split of folks who would be qualified.
Yeah.
And so we definitely have a problem when it comes to medical schools. We need to build more. But the reality is we can only produce as many doctors as we have residency slots.
Mm.
So building medical schools without increasing residency slots, all that will do is increase the size of the bottleneck, right? Because you make it wider essentially. Because if we don't produce more residency slots than we're currently producing, we're not going to have any more doctors at an annual level. So, we like to focus most of our work when it comes to the doctor shortage on how to address the residency bottleneck. And so, there's two things I'll say here. One is when it comes to international physicians, this is why new pathways that get around the residency bottleneck are so important.
Yeah.
Because there are a lot of doctors that already did their residency, yet we essentially, when they moved to the United States, we asked them to get in line with everyone else.
Yeah.
And it's really unhelpful
Mm.
because that bottleneck is what prevents us from addressing our physician shortage. So that's one. This new, now almost we have almost 20 states that have created this pathway. It's a major solution. But secondly, we also need to pursue solutions that increase the amount of residency slots on offer.
Mm.
We now have a situation where the AMA is even supportive of adding more residency slots, where they were initially involved in sort of the constraining and the restricting of residency positions. Now, most of these doctor groups, everyone sees the benefit of more residency slots, but we don't have the funding. And the way the formula is structured, there's no guarantee that if we just add slots that it's going to go to primary care or psychiatry, or it's going to go to rural areas. And so there's a lot of policy solutions and good research needed to figure out how we get more residency slots and how we make sure those residency slots go to where we need them.
Yeah, yeah, because and one of those reasons is the funding, right? That the funding
Yeah.
is tied to Medicare,
Yeah.
patients, right? Like, so hospitals that have more Medicare will get more spots, and so you'll end up kind of like a inequities when it comes to areas that really need residency, facilities, won't get them
Yeah.
eventually.
Yeah, there's sort of two. Yeah, there's several ways that so just to step back a little bit, of the residency slots that we have funded in terms of like federal funding going to these slots, it's important to note that one, states often also fund. Texas recently, I think, dedicated around $500 million to new residency slots. States can fund slots. Philanthropists
Mm,
can donate money to fund new residency slots. You or I could donate money to fund, like, there's no restrictions on other money going to fund
yeah,
residency slots, but Medicare, which funds around 75% of the federally funded slots, Medicare covers 75% of them. We did cap in 1997 on a per program basis what Medicare will reimburse for and what Medicare
yeah,
will fund. And so as a result, what that did was that kind of locked in the dynamics that existed in 97, which still persists today. That is that money often will go to large urban programs, because not only does, you think about money being tied to Medicare patients, but not only that, but money is largely tied to the cost of the procedures the residents are performing.
yeah.
And so in a higher cost area, those procedures are going to cost more, and those areas are going to get a higher reimbursement, and that's going to draw funding there. In addition to that, the money goes to inpatient. It
Mhm,
goes to inpatient facilities, and so as a result, you have primary care doctors not necessarily being trained where they're going to be performing primary care traditionally, um,
mhm,
and so you sort of have a mismatch of both the geographic distribution, where money is not going to rural areas where it should be, but also specialty mix. The
mhm,
money is largely going to finance highly paid specialists, and there isn't sort of any corrections being done. There's small corrections, but there isn't a full scale sort of rethink of these dollars to ensure that it goes to primary care, and so that contributes to the shortage in the maldistribution.
Yeah, and so and this is, as you said, this has been going on since 1997, and it's
Yeah,
been a challenge to get any policy across Washington D.C. and trying to states eventually said, "Hey, like, we're doing this on our own." A lot
right.
of states came up with alternative pathways, licenses, and most people I speak to is like, they're like, we need everything, right? We need more medical schools, we need more residency spots, we need alternative pathways. It's a problem of speed, right? We don't have enough doctors to keep up with the demanding population, the aging population. So the faster we can get there, the better. So we need all solutions. Do you agree with that type of thinking? People say that, hey, we need every type of solution possible.
I do largely agree that this is a, let many flowers bloom, pursue all avenues. But I think it's important to, like you said, to recognize which of these plays are long term and which of these are short term. Because the
Mm,
reality is we're in a crisis. This isn't like we're approaching a physician shortage issue. There's a lot of rural areas that have an acute physician shortage problem. And
yeah.
so this is where, I get a lot of questions when I'm working on this international physician licensing bill, where people are so surprised to hear that it's only since 2023, 2024 that we have like significant amount of states pursuing these pathways. And I think this is largely a function of the residency problem, the residency
Mm,
bottleneck. Because the reality is, if we did not have a residency bottleneck, if we had enough residency positions, it would be inconvenient for
yeah.
a Israeli, a Irish, a,
Mhm,
um, an Indian doctor to move to the United States and have to repeat their
yeah.
residency. But if they could guarantee that they'd get matched right away and know that all it would take is 2 to 4 years, or three to 4 years, and they could start practicing,
Exactly.
that's one thing. That's one thing.
Yeah.
It's still inconvenient, but the fact that they know that they don't actually have that good of a shot to get
Mm,
matched, and it costs so much, and they'll have to wait in line with everyone else. Um, you know, it. I think it makes the problem a lot larger, and it's one of the reasons why you have states doing this now. Um, this is something that should have been done a long time ago. To be clear, this should have been done years and years ago. We should have had these pathways in place to ensure folks could practice as quickly as possible. But it does make sense that as the residency bottleneck has gotten worse and the physician shortage has gotten worse, states start to take it more seriously without federal action.
Yeah, yeah, and I was just speaking with a physician here in Washington State. He owns multiple ambulatory surgery centers, so
Mhm.
he's like a specialist. Does seminars around the world. He's known for his techniques, and he wanted to bring a colleague of his from the UK who's a specialist like him, like really great, like world known. Um, and um, and then he was brought here, but he was told to redo the exams, and he was like, "Hey, I'm not gonna redo the exams," you know,
Right.
and so he didn't come, and he didn't help out. So those are some of the things that just don't make sense. Like, why would we put on so much restrictions, when we know, like, from somebody from the UK who we already know, like, is a specialist and his articles are everywhere. So that sometimes policy doesn't make sense.
Yeah, no, it's all about striking a balance between sort of like common sense and then the necessary safeguards that
Yeah.
medical boards, doctors, everyone can agree with. But I think in general, it's important to keep in mind that, when we think about safeguards, when we think about patient safety, oftentimes we have this idea that, we need medical boards to be heavily involved and mandating all these things because we think of them as sort of the final line or like the last line of protection. But the reality is, we have a large and growing medical malpractice industry, and
Yeah.
employers have to pay those. Employers are the ones that are held accountable
Mm,
when a doctor makes a mistake, and employers are the ones that sort of bear that risk. So,
mm,
we have to realize that we have a pretty good system for ensuring that incentives are aligned, so that employers, are essentially punished if they don't take necessary precautions and ensure patient safety. They're the ones that bear that. And so, we can have sensible, reasonable guidelines, and then trust that the employer credentialing process, which is very
mm.
thorough, and they make sure it's very thorough, that we can trust that is operating appropriately.
Yeah, yeah, and it's just so funny, Lawson, because as you said, we're having an acute problem. I see that because a couple years ago, when I used to reach out to some employers and say, "Hey, like, you guys should try this alternative pathway," they were like, "Hell no! Like, we're not going to try this. This is not for us. We don't do this. We only hire board certified physicians. That's our
Right.
main thing." And right now they called me, they were like, "Hey, we really need physicians. We're ready to try this pathway." So and then it hit me. I'm like, "Hey, this is the people are really feeling the problem, and this is it's not about when, but it's about if, because you're seeing all these specialty boards as well, the ABMS and other specialty boards saying, hey, like, we're open to board certifying like anybody who meets these criterias, where before they were very quiet."
Yeah, we were really excited. I mean, we wrote a piece recently highlighting ABIM, the Board of Internal Medicine, for starting a pilot program. I think you've also posted about this. Start a pilot program, and it's specifically designed for doctors advancing through these new pathways. And I mean, we only have a handful of doctors that have even begun these new pathways. So to see one of the major primary care boards come out and say, we're creating an alternative pathway specifically to make sure that these doctors are able to get employed, I think speaks to a general like shift in the
Mhm.
way the associations, in the way the sort of medical establishment is viewing. Because I mean, 5 years ago, I mean, you know better than I don't think we would have thought that that was in the cards.
Yeah.
That this would be that doctors going through these pathways would be legitimized in the appropriate way that they are now. So I was thrilled to see Board of Internal Medicine, because once a board of that size and of that influence comes out and does this, that it's sort of the first domino, or
Yeah.
the third. I know other boards have come out and said similar things and are pursuing other types of pilot programs, but we suspect those are the first dominoes to fall, and particularly, hopefully, with other primary care specialties, you'll see that, and you'll see more opportunities to sit for exams for the folks that go through these pathways in the next few years.
Yeah, yeah, yeah. Where do you think this goes from here? Like, do you think basically, because I spoke with a lot of physicians who are who are against this policy and are like, hey, this is not a good thing, and it should be done how it was traditionally done. They're like, hey, if this kind of gets out of hand, then residency will be evaporated, basically, like, for all students, and everybody will demand an alternative pathway. So how would you respond to that?
Yeah, I think it's important to keep in mind that the for most of these states, the goal of these policies is to essentially upskill workers who are forced to be or underemployed as a
Mm,
result of both the residency bottleneck and a lack of permissive licensing. So, you know, you can think about the long-term implications of this, but I think that's the secondary question. The first question is, how do you ensure that we do not have doctors who practice successfully for 20 years moving to the United States and instead having to be a taxi driver or open a power wash business? And not that those jobs are not meaningful or important, but as a country, from a policy perspective, we
mhm,
cannot leave doctors on the sidelines. Um,
yeah,
and so I think the most important thing is, how do you first get doctors that we currently have that have been practicing off the sidelines, create supervision to make sure that, if they've been out of practice for a little bit, they have, some supervision to ensure that they get back up to speed. They have folks keeping an eye on them as they work with patients, and then get fully licensed. And then secondly, then we can start talking about, what does it look like? How do we think about international residency programs? And the reality is that so much of these international residency programs model a lot of their work after what the U.S. programs do.
mhm,
And so I think there's a second part of this, both from an immigration question of, like, what do we do with H-1Bs now that this makes it a lot easier? But secondly, I think it's important to know, because a lot of the people that have
yeah,
these criticisms are often coming at it from an angle of, we should be prioritizing American doctors.
mhm,
And that's a position many hold. And so, I'm not here to sort of argue with the question of who we should be prioritizing. But folks who hold that opinion should recognize that there are a lot of US trained doctors that don't necessarily match to residency. And the
yeah,
reality is that they're in line with a lot of immigrant doctors who have already done their residency. And that's part of the reason why they don't match. And so,
yeah,
opening up, when these pathways are opened, this opens up more residency positions for U.S. trained doctors as well.
yeah.
It's not just designed for immigrant doctors. It's actually designed as a way to lower the pressure on the residency bottleneck in general.
Yeah. So yeah, you're right. So when you have two different pathways, basically everybody matches to their, qualifications. Somebody has done a residency back home and is very qualified and, has a lot of experience. They can, get into the alternative pathway. If somebody, like, if there's a US medical graduate that didn't complete residency, they can do the residency. So you're saying this is like, it opens multiple pathways for everybody.
Yeah, I think it's important to think of it as not just designed for international doctors, but it's also designed for the system as a whole to relieve pressure on everyone.
Yeah.
Because we should not be having folks who did their residency already successfully, safely, in line with the same folks who have not completed their residency. It just does not make any sense. Um,
Yeah.
and we have reasonable safeguards to ensure that we keep patients safe. And with
Yeah.
those safeguards, that's the most important thing. So yeah, so I don't know if the right thing is to say that it's like multiple pathways. I think it's really one pathway. The pathway is a residency program, but
Yeah.
the reality is we shouldn't be making someone repeat it.
Yeah.
And then I think there's other questions to be had of, folks who are performing. Washington's a unique
Mm,
example, where you
mm,
have folks practicing, seeing patients, performing care in under a temporary pathway. And how do you make sure those folks can start practicing permanently is an open question.
yeah.
But I think it's important to think of, most of these states have passed bills that still require residency.
Yeah.
They're bypassing the bottleneck, but we're not bypassing residency. Most of these states that pass these bills.
Yeah, that's true. That's true. That's true. And eventually, like, and I agree with you. It's still an open question. It's a question that we're just trying to figure out here in Washington how that happens. Yeah, but yeah, you're right. Most states done that, and I'm just really excited to see where it goes. Especially right now that I'm glad that billing is coming around. A lot of people are not having issues with, especially Medicaid and Medicare. The private sector is a little bit difficult, Lawson, and
Yeah.
where do you think how can advocates really bring payers on board to this?
Yeah, it's a good question. I think that to be honest, I think the most important thing is successful implementation of existing pathways. And,
Mhm.
and more states jumping on board, of course, passing more bills. Because the reality is, to convince payers, you have to show you need to have a track record. And so Washington's a great example where you guys got out ahead of this, and you
Yeah.
got doctors practicing, you got IMGs in the workforce, and you see those successes, and that's one of the better ways you can to convince payers. But also, there's a lot of states that have passed these permanent pathways,
Yeah.
and so I know in Illinois, you've got folks applying, in Tennessee. Um, so, you know, I think the most important thing is having successful implementation of the existing pathways, having examples, being able to say, here's 20 doctors that are practicing, that are seeing patients using this pathway, and it's working well. And I think over time, similar with the specialty boards, once we hit critical mass, which we're approaching, we're almost half a states,
Yeah.
once we hit critical mass, everyone's going to have to get on board. And
Yeah.
so, and that's the most important thing is just more states. We currently have, I think eight, maybe seven states with active legislation,
Mhm.
getting those across the finish line, and keeping up this pace, so that we don't stall out, and that we have states in every region that are doing this.
Yeah, yeah, I agree with you, man. Especially like if the big states like California and I know Texas got one, which is amazing.
Yeah, that's
Uh,
yeah,
Yeah, that's huge because like that's an opportunity because Texas is a big state. That's an opportunity for a lot of patients out there and a lot of IMGs and to find some jobs, and take care of the community. So Lawson, I agree with you, man, because it's gonna take case studies, right? It's gonna take seminars. It's gonna take like conversations. I was just speaking with a hospital the other day, and they were like, we would love to try this, but we don't want to be the first one. So
yeah,
like they didn't say that exactly, but that was the kind of the conversation that I came out of with it. So
sure, sure.
so is that the common thing that you hear, like I'm not going to be the first one to try this?
I mean, so I it's a good question. I think there's some financial questions for these hospitals, right? Because the reality is there isn't necessarily certainty that you have board certification on the table, right? For a lot of
Yeah.
these doctors.
Mhm.
And so what it does is it puts us in a position where you're going to have to get malpractice insurance, and that medical malpractice insurance is going to be more expensive for a doctor that isn't board certified. And as a result of that, it's likely that it might be bigger hospitals that are better positioned to take advantage of this pathway to be able to hire doctors, because it's a lot different for a small hospital or a small clinic to deal with the more expensive malpractice insurance. So
Yeah.
that's one financial component of it. I could understand, a smaller hospital saying, I might have to wait to see until we can make sure there's board certification. We have examples to try to lower the medical malpractice insurance, and that's just one aspect of this. I understand, like, there's also other parts of this that aren't just financial or about malpractice, but I think that's part of it. Is like we want to be able to get some of these big hospitals on board, get them hiring doctors, putting them in rural areas, and I think that's probably a really good starting point. I mean, Tennessee with HCA is a good example.
Yeah.
HCA hires these doctors, that changes the game.
That yeah, that's huge. They're like everywhere, right?
Yes.
Um so but I agree with you, man. Like for example, what I'm seeing personally is that hospitals like community hospitals in rural areas, remote areas, they're open to trying this. Actually, there's I spoke with a few guys that are trying something in Othello, Washington, right? And so they're trying to get like a critical hospital right there. And I was like, hey, you know what? This is a great idea. So they're open to this, but when it comes to like larger health systems, like they always like refer to like bylaws and board certification and all that. And it is frustrating, but I think, Lawson, over time, like people will come around, eventually.
Of
That's what I
course.
feel like.
Yeah.
The problem is very acute. And because I've seen it in community health centers, a lot of community health centers, FQHCs, were like, we're not doing this because of, NCQA and all that. And right now they're pushing NCQA to change their policies. Hey, we need more doctors. You guys got to work with us. So
Yeah.
I feel like it's just like a dominoes. If the hospital gets on board, then the payers get on board. Then it's like, it's just about time. That's how I feel.
100%. Yeah. I think with particularly with rural areas, I mean, the shortage is so acute. I mean, on the Hill, we Niskanen, we work on the Hill a lot. We're meeting with lawmakers. I mean, when you talk to these senators or reps in rural states, it's just they're like anything to get more doctors to my district,
Mm.
because that's all they hear from their constituents is we need more doctors. We need more doctors in this rural area. We need more primary care. We need more ERs. We need more ER capacity, and that's what they're hearing over and over again. And so at this point, I mean, I think that's why you see a success of. I mean, I think it's fair to think about this current political climate when it comes to immigration. You have red states,
Yeah.
deep red states, saying, you know what, I'm going to go all in on this
Yeah.
and make sure that my state gets doctors. I don't care about the immigration question. We need doctors here.
Hmm.
And then you have blue states doing the same thing. So the doctor shortage transcends politics.
Yeah.
Normally, when you're dealing with something like this, a movement that's sweeping the nation, you kind of see red states first or blue states first, and then you kind of have to convince folks. This has been an entirely different kind of process. It's anyone and everyone because every state needs more doctors.
Yeah, yeah, this is totally a bipartisan issue, man. When I speak with people, regardless of what their political beliefs are, they're like, "Oh, you know what? This is a great idea." I don't know why we have like very educated people working as Uber drivers, because
Right.
even like, yeah, if you ask anybody, and that's why I think the number of IMGs there hasn't been like enough data on, and knowing, hey, how many qualified IMGs are in America. Like we don't know that number
Yeah. We
because
don't know. Yeah.
you'll see like every person you ask, hey, do you know like like somebody who's a doctor and can practice here? Everybody will say, yes, I know one or two people,
Hmm.
right? Regardless of who you ask. If you just go to a random airport and you just ask somebody, they'll tell you that they know somebody. So it's just
Yeah.
I think it's just it's just a huge opportunity that we're not taking part of.
Yeah, for sure. And I think oftentimes, we highlight the big stories like, oh, this general surgeon is a taxi driver, but there's also a lot of very small, upskilling problems of like a lot of these doctors may still pursue a career in medicine, but they have to start at the bottom. Like I know, my colleague has a phlebotomist who
Mhm.
was a primary care doctor for 25 years in Iran.
Wow.
And you think about that sort of like they had to they go through the work of training to be a phlebotomist and get that certification, and they're getting paid way less than they would if they were able to get a residency slot and go through that process and afford that. And so a lot of times, or medical coding, a lot of folks go into medical
Yeah.
billing coding, or even medical consulting, devices sales, where their actual credentials are far beyond that. And it's not to say that those jobs aren't needed,
Yeah.
but as a country, economically, we have to think about upskilling, in addressing the shortage, and that's where you want that phlebotomy position to be able to go to someone else who needs it, and that Iranian primary care doctor to be able to treat patients. Yeah.
Yeah. Yeah. So, Lawson, what do you think? States. Let's say if somebody's listening to the show and they're in a state that doesn't have an IMG policy and they really care about this issue. Um, what should they do? Like, if you just maybe like, how can they start? Like, how can they get started to say like, hey, like I want to make sure like my state takes advantage of this as well.
Yeah, I mean, first off, I would say reach out to us. I know, I won't speak for Mohammed, but please reach out to
Reach
me.
out to me too.
Yeah, reach out to Mohammed, others that work on this issue, because there's a chance that there may be something happening in that state that we can let you know about. Also, I mean, feel free to do your research. There's a good chance we almost have every state where at least a bill has been introduced at some point, and see who that sponsor was. It might be your senator, it might be your representative. And then I think third is just contact your reps. I think that there's if you want to do what you can to address the physician shortage, try to let your representative know, that this is an important issue to you, that you've particularly if you've experienced it directly, the issue with healthcare scarcity in America, and be able to make that pitch. Because I do think that it's going to continue sweeping the country. We're going to continue to have states jump on. But in order for that to happen, a lawmaker or a committee staff, someone needs to be aware of it, be
Mhm.
convinced of it, and then get passionate about it. And so sometimes all it takes is one phone call or one message, and it gets the ball rolling.
Yeah. Okay. On the other side, let's say somebody's an IMG, and they're like they want to like share their story out there. Like they're in a state that's currently introducing this or participate. How can they get started? Is it the same as well? Just reaching out to their representative and sharing their story, or how can they get started?
Yeah, I was gonna say like tell Mohammed because you've been doing a really good job at telling folks stories and also connecting folks because there's going to be opportunities over the next few years to share your story, to potentially write, to speak, to talk about how these pathways are affecting you positively. So I think that getting plugged into the academy, the TIMGA, to other groups, Project IMG, that are working on this, and let them know that you're a doctor who is interested in this policy, who's keeping an eye on it, because it, I, as a non-doctor, can talk about this all I want, but it's not nearly as impactful as when an actual internationally trained physician or international graduate or MD jumps on and talks about this.
Yeah.
So yeah, however you can get involved.
Totally agree, man. Lastly, how can people, reach out to you or get in touch with you if they want to like learn more about the Niskanen Center or just, get some information and, participate as well?
Yeah, I mean, I'm sure you'll tag me here on LinkedIn, so feel free
Yep.
to connect, and jump in my DMs and we can talk if you're thinking about this. Also, niskanencenter.org. You can find my email on there and see what else we've written about. We have a paper coming out probably in early December. We had the pleasure of bringing on Jonathan Wolfson as a senior fellow at the Niskanen Center. He is what I would call one of the architects of these pathways. He originally worked at
100%. Yeah.
Cicero Institute, where they wrote some of these initial sample legislation, got this across the finish line in at least a dozen different states. So I'm really happy to have him on. We're writing a paper together that's sort of focusing on kind of what's next, which is we have a critical mass of these states that have passed bills, but our concern is that you have a lot of these states that either it took a while for these rules to get written, or you have medical boards that may want to come in and kludge up the process. And so we
Mm,
have a paper coming out about first of all doing another survey of like where we're at, what are all these states, what are the details of all this legislation. We'll have like sort of a tool that you can see and use to see where your state's at. And then we're going to go in and have similar details about implementation,
yeah.
advice to medical boards, advice to employers about how to make sure that when you pass one of these bills, you can quickly get it enacted, quickly get the application up, and get doctors practicing, employers willing to hire them.
Wow, man, I'm looking forward to that paper and, looking forward to, using that tool myself. So thank you guys for working on it. Lawson Mansell, everybody, health policy analyst at the Niskanen Center. Thank you so much, Lawson, for coming on the show and, sharing a wealth of information.
Yeah, it was great. Thanks so much.